Welcome to the CCO Technical Advisory Group for the March meeting. My name is Jen Davis. I am a policy analyst and project manager within the Quimsy team in the Office of Health Analytics at OHA. Happy to be your host for the afternoon. We do have a shortened meeting today. It's just an hour long, but we do have quite a few agenda items to get through. So I think we can go ahead and move to the next slide. Logistical and housekeeping items are the same as they are every month. Well, actually, with one exception, if you do have logistical questions for this month, please use the chat function to message Joanna Yan. She is helping us out this month as Brian Toops has moved to another position in the agency. So Joanna will be your person for those types of logistical questions. Other questions and comments? And then if you are wanting to speak, we would welcome those comments, but if possible, we do ask that you can turn on your camera when you're speaking. And then last but not least, in terms of naming convention in the participant list, if you could make sure that you have your full name and your organization's name included, that would help us in just taking attendance and making sure that we're keeping an accurate list of who's attending. Next slide, please. Okay, in terms of that shortened agenda today, we do have several updates, which we'll go through in the next few slides. Then we have a presentation from Colleen Ruland at OPIP about social emotional health measure and just a couple clarifications on that. Then we have a presentation from Katie Howard at OHA on social determinants of health, that measure, and some future updates. Finally, the health equity measure, a presentation on that with future updates and Q&A, and that will also be by Katie Howard. So a busy day for her. We can go ahead and move to the next slide. Okay, the updates portion of the agenda. One more slide, please. And I believe I am first up this month with the metrics validation process. If you can move one more slide. For calendar year 2022, we are coming up. Oh, sorry, back one, the one that says CY. Yep, perfect. We wanted to review for calendar year 2022 what the validation process and timeline look like. It is all very similar to prior years if you've been here for a while, but it never hurts to go over that information again. So the first thing that's coming up next Friday, March 31st, that's the deadline for claims submission to OHA for inclusion in 2022 results. So I'm sure everyone is aware, but just make sure that those claims are submitted by that date. During the month of April, OHA, we will be working hard internally to create the calendar year 2022 dashboards, which we will share via SharePoint by April 28th. CCOs will then have from April 28th until May 31st to review those data, ask any questions, submit any validation requests, supporting documentation, etc. on the 2022 metrics to us. And the email is listed there on the screen. It's the usual metrics.questions that you submit questions to during the measurement year. We will be working hard to resolve all of those validation requests and questions and get final metrics turned around and distributed to CCOs, quality pool payment amounts calculated, and those sent out to CCO CEOs all by June 16th. So that is the date when you will know for sure the final results of your metrics, as well as the amount of the quality pool and challenge pool, if applicable, that will be distributed to your CCO. And those financial distributions will happen by June 30th. I would also note we do have a full timeline and due dates document on the CCO metrics webpage. That's really handy because it also contains due dates and timelines associated with some of our other measures. So like EHR measures, some of the attestation measures, things like that. Those due dates are also listed on that document. Okay, next slide, please. And if you have any questions as I'm going through, feel free to drop them in the chat or raise your hand. So a couple other just miscellaneous metrics program updates that I wanted to make you aware of. First of all, we are working internally on a timeline of quarterly dashboard and monthly data releases. That's something that we heard from a couple of you would be helpful to know when to expect those things. So we're working on a timeline for that, as well as like a templated layout. So if that's helpful to you in ingesting the data, you can have that at your fingertips. The other thing to know is that there has been a change in the HEDIS metrics for 2023. HEDIS has implemented an exclusion of members deceased during the measurement year. So that is something that we will intend to include once we move into the 2023 measurement year calculations, the first of which should be distributed in July. And then finally, we wanted to give you all a heads up for the 2024 CCO contract. We have proposed a change to move the validation deadline to May 21st. It is currently May 31st. As you saw on the last slide, there's a pretty tight turnaround for once all the validation requests are submitted to us to then do the research, make decisions on those, and then finalize the metrics in time to ensure prompt payment for the CCOs. So we're considering moving that, or proposing to move that deadline up by about a week and a half, so that we can make sure that we're able to turn around those metrics results and quality pool dollars to you as quickly as possible. I think that is it for my slides. Next slide, please. Okay, I will pass it over to Sarah Kleinschmidt to talk about metrics and scoring committee work.
Hi, everyone. Sarah Kleinschmidt. I use she, her pronouns. I work closely with the Metrics and Scoring Committee and do other work on the metrics program. So this is the timeline for the Metrics and Scoring Committee. I think things that I wanted to point out to you all are noting that things are subject to change. So the committee in May is kind of when they'll, well, actually this next meeting in April is when they'll start pivoting their work and thinking about selecting incentive measures for 2024. And as they do that, if you'll recall the last few years, what they've done is had a process where they select a draft measure set and then have left that open for a month before making final decisions. And one thing that they've been considering for this year is potentially leaving that draft decision open longer to allow more time for reflection and public comment. So I do want to note that. So right now we have July as the date when they would finalize the incentive measure set. But potentially that may shift. So, and we will keep you all updated through the tag, and then we will also be sending out information at the point when they do select a draft incentive measure set, so that folks can provide comments, etc. So that's what I have, Jen. Happy to answer any questions on the timeline.
Thank you, Sarah. I don't see any questions. We can move to the next slide. And I will turn it over to Katie Howard to talk about SBIRT.
Thanks. Excuse me. We will be updating the measurement year 2023 technical specs for SBIRT. We added hospice this year as an exclusion. So one of the exclusions is the hospice assessment with the LOINC code on the screen. We did not include that it had to be paired with the YES SNOMED code. And so we will be making that update to the technical specifications, but the hospital assessment should indicate that they need hospice services to qualify for the exclusion.
Thanks, Katie. Okay, not seeing any questions or hands, so we can go ahead and move on, and we are right back on time. So thank you everyone for moving quickly through that. At this point, I'm going to welcome Colleen Ruland back to the tag to give us a presentation on some clarifications on the system level social emotional health metric. And Colleen, I believe you are a co-host of this meeting, so if you'd like to do the slides yourself, feel free. Otherwise, we can tap through for you.
Great, that'd be great if I could do them, just because I tried to break out the information a little bit. Thank you. All right, does that look right, Jen?
Yes, that's looking good.
Not my talking notes. Okay. Hi, I'm Colleen Ruland. I'm the director of the Oregon Pediatric Improvement Partnership, and we co-developed the system level social emotional metric with the Children's Institute. And I've been asked to provide some clarifications around the section related to asset mapping. And thankfully, OPIP has done that work on the front line in 13 different communities. So what I thought I'd share is just, again, like, why are we doing that? And then some details around that were informed by our personal experience, having collected them ourselves. So anchoring. System level social emotional metric has 4 different components. The clarification I'm going to be providing today is on component 2, which is the purpose of the component 2 is if we know there's a certain percentage of children who are getting social emotional services, the purpose of component 2 in this glide path system level metric is to help you as a CCO understand, is the reason that the rates are what they are because we don't have providers who can provide those services? Is the reason that the rates are what they are because we have providers, but they don't provide services or look like our members in a way that limits access? And why that information is helpful in a system level glide path metric is, you know how many children are getting these CCO covered services. This is the way you can understand, do you actually have providers that you contract that see this population? And then that combination of information is then meant to inform and share what you share with the community in component 3 in order to design an action plan that would improve CCO covered services, which may be addressing gaps in the providers that are available that you contract with to see young children that you would identify through the asset map. So in 2022, you started first with an asset map of the specialty behavioral health providers. In 2023, you update that map to understand whether that increased or decreased and whether the populations with historical and contemporary inequitable outcomes, whether there were providers that address their needs. But then you expand this year to another group of people you contract with that could potentially be providers who provide services, social emotional services for young children. So you're in that 2023 space. And so there have been some questions that relative to the specs that people have asked us to just clarify, which is what I'm going to do today. So in your technical specifications on page 5, it describes the asset mapping, which obviously in 2022 was just specialty behavioral health, 2023, specialty behavioral health plus integrated behavioral health. And so in the specs, it says within the measurement year, the CCO needs to develop an asset map to capture services and resources in the region that address social emotional health by using a standard asset map form anchored to the evidence-based services and with specific indicators that impact access to services. So some folks have asked, like, what do you mean in terms of the content, not the format, but the content of the standardized asset map? And so that the content of the asset map is what is provided on page 20 of the specifications. Recognizing the table format, how you do it, that's optional, but in terms of the content of what we meant in asset map to capture services and resources in the service region. And so that the rows in that table are your helpful guides of what did we mean when we said evidence-based services, the kinds of indicators that impact access. Back to the why. Why does it matter how many people see children, whether they have capacity, what their race, ethnicity is, what their language is? Those are things that impact whether the current providers have any bandwidth to expand referrals. So again, if the goal of this asset map is to understand, do we have providers that can see more children? Because component 1 told you not enough children are getting recommended services. Those first rows are really help to inform you, 1, whether you have providers that are in integrated behavioral health who see birth to 5, they may see older age groups only, and that's actually really common. The second thing is just understand if they're there, do they have any capacity for new referrals? I'm sure you've heard from a lot of the practices you work with that those integrated behavioral health are pretty slammed. And so that's information that's helpful to you in terms of, like, could we expand that ability for that to be an asset for us, or is that asset already capped and that's how you're getting the rates that you're getting? And then, as you know, in order to provide culturally and linguistically appropriate care, it does impact access and receipt of services depending upon the provider's race, ethnicity, and language. So then the second part of the specs on page 20 is really around the evidence-based services that are provided. And obviously in your specialty behavioral health, what specialty behavioral health provides are services that are therapeutic services, therapies. For integrated behavioral health, they provide a broader set of service modalities because they are in an integrated primary care setting. And so the kinds of things that they could do that could impact social emotional covered services by a CCO would be starting with secondary screenings and assessments based on issues that have been identified in order to inform either what they would do or to inform their referrals. So that's that row of screening and assessments in terms of that service modality that an integrated behavioral health does. The second is that they might do brief interventions, and those brief interventions would be considered a therapeutic service. And so that's the next row. And then the third, while not common and not highly prevalent in the work we've done in the last decade, there may be some integrated behavioral health that you contract with that provide dyadic therapies in alignment with evidence-based dissemination of those modalities. It's very common for integrated behavioral health to actually do brief interventions that are parent management strategies informed by therapeutic models, therapy service models like PCIT, but they're not doing full PCIT. So that was the difference between the brief intervention and the therapy services. And then again, because this is an evolving world, we always just wanted to add an other of another type of social emotional service not captured above. So in terms of what you have to turn in, you have options. So the goal for what you have to turn in is you have to turn in information that addresses the circles that are on page 5 of the technical specifications. So location, county, number of providers, capacity for referrals, race, ethnicity of providers, language, and then service modalities. And again, the technical specs are written for all 3 years in terms of what you have to turn in. And as you know, specialty behavioral health providers provide therapeutic modalities. I just explained integrated behavioral health has kind of a broader continuum. And then in year 3, those early learning providers are going to have different service modalities. So one of the questions has been, okay, what do you mean by service modalities provided? And so definition of modality is intervention. So specific to specialty behavioral health, obviously the service modality they provide is therapies. So that was why the asset map was anchored to that. For integrated behavioral health, as I just mentioned, the service modalities or the service interventions that they provide are those things that are aligned with the kind of content rows that are in the table: screenings and assessments, therapy, brief intervention, therapy services. So in terms of what you turn in, you have to achieve that circle of describing the service modalities that are provided. Options that you have to kind of operationalize that kind of requirement that is anchored to the bullets is you could use the table format that's provided on page 20 of the technical specifications. You could use the OHA fillable asset map. The one thing I want to note, and I had it on the last slide because it led to just a little bit of confusion, is the OHA asset map, sorry to flip back, has all the rows that are in page 20. It's just in a different order. So the OHA fillable asset map has that therapeutic services first, and that just may be a little confusing for some integrated behavioral health. It's awesome for entering, but they usually think of like the continuum, and because so few of them might be doing those ones, that may be a place that leads to some confusion if you start with there. But so your options in terms of what you turn in, again, the requirement is the circles, the bullets that are there to align with the tech specs on page 5. And then in terms of how you do that, you can use those 2 formats, or you can use a different format. I know OHA would recommend that you use one of those 2 formats, given they'll be getting a lot of information from different CCOs, and that helps to standardize the information. Are there any questions in the, is it chat? Is that function working so I can make sure that I answer them?
I don't see any questions yet, but let's pause for a minute just in case folks are digesting.
Sure.
I have a question.
Sure. Hi, Rebecca.
Hi, Colleen. Rebecca Valley, she, her,
Hi.
CPCCO. Hi. One thing that we're finding in trying to interpret this is the language about assessing PCPCH clinics where we assign members 0 to 5. And as we are doing our outreach, we're finding, not surprisingly, that a lot of those providers do not serve 0 to 5 or aren't trained to. And so in terms of filling out the asset map, should we, do we list those providers? Because yes, they are part of an integrated behavioral health model. And do we just say nothing, or do we not put those providers in?
Yeah, I wish I had the tech spec on that. Because we actually put that in the curious questions and things you should be documenting. You don't need to turn that into OHA to get credit, because page 5 is the OHA credit. But in the tech specs where we talk about what you should share in component 3 in terms of the learning, what we have done is it's actually really helpful for people to know, okay, this is how many PCPCH sites we contract with that have told us that they attested 3C3 and they have integrated behavioral health. Because from your CCO, that's all the information you have right now. So you're assuming we have providers. So then the next step, and the reason you get to this, right, is so you're first going to have a drop off there of how many do you contract that are PCPCHs? How many said that they do 3C3? How many see birth to 5? You might have a little bit of a drop off there. And so this aligns with component 3 specs. But then where I am telling you, I predict it'll be very high. This is the purpose of this system level metric, is to give you the ahas to inform the action plan before we jump to a child level metric. It will not surprise me if a large number, a majority, then dip very low, that they have integrated behavior, of the ones who have integrated behavioral health, which I think the program, I can't remember what Amy told me about the percentage, but it is to be expected that it'll be low. That's the aha we wanted in terms of forming the action plan. So I think for you as a CCO and forming component 3, that is aligned with the specs of what did you learn in that experience? And what does that mean in terms of what you actually have to turn into OHA? By virtue, they'll somewhat know it, on the back end, because they know, you have to, they have the PCPCH rate. So in terms of the number of providers who currently serve birth to 5, you just have to enter that per the specs for those who got to that next low. So no, I as a measure steward, and I'm sure OHA, I won't speak on their behalf, would not be surprised if you actually end up turning in a very small number for that, because that was the aha intended. Does that help, Rebecca?
Yes, absolutely. Thank you.
And I will just say, of those who are seeing birth to 5, in terms of these rows of the service modalities that integrated behavioral health, also do not be shocked if they also don't do those things. That's what we need to know in order to know where we're starting, in order to get where we're going, because there's a reason we are at 5% statewide, right? And so the whole point of this is how do you empower and inform each lever, but you need to know where your lever is in order to understand that piece.
Thank you. Any other questions for Colleen?
Hi, this is Michelle Kirchhoff from Shoreline Health Plan. I had a question about also identifying the behavioral health provider groups.
Yeah.
For just in general, trying to look at the taxonomy codes to include to target for that specific group of individuals. Am I going to use just the taxonomy codes that are identified in the taxonomy or the hacker value set, or is it any OHA identified behavioral health taxonomies?
I'm so glad you asked that question. So in the specs, we were trying to think about what are levers that CCOs have now? What is data that they have? We were trying to do this in the most least administrative burdensome way. And so within this IBA integrated behavioral health asset map, it is intentionally written to be how many practices are of the PCPCHs that you contract with, because per your CCO contract, you're supposed to know whether they're a PCPCH or not, right? And then of those that you contract with, how many attested to 3C3? And so that's where you start, Michelle, is what PCPCH sites attested to 3C3. And there are two ways you can get to that. One is, or maybe there's three. I'd love to hear from other people. But in my experience, having done this as our organization, and then in working with CCOs, there's two ways. One is CCOs maintain that attestation because it's informing their required BBPs to PCPCHs and their integrated behavioral health. The other, and Jen could share this, or it could be shared on the Learning Collaborative, is the PCPCH program has that information for every practice that has attested to PCPCH. So there is a way to request from the PCPCH program. These are the PCPCHs that we contract. It's a password locked file. And then you could use that to see, did they attest to 3C3? And so that was our way of trying to think about a very clean, systematic way to get to who you would be reaching out to, anchored to data that CCOs are supposed to have. Does that help?
Well, that sounds like it's targeting the PCPCH identification, but I was talking about the behavioral health specialists.
Oh, you're back to the
target
asset,
them.
the other asset map?
Yeah.
Yeah.
Just to make sure that I was doing it right in the first year. I think I did, but you know.
Yeah. That is anchored. There's contract language that we aligned. It was really, OHA behavioral health was really helpful to us, of like, there's contract language of who you need to, as a CCO, contract with for behavioral health services. So we took that language for the asset map, and that's what we used in terms of who you start with. And work that I've done with CCOs, you all do this a little bit differently. So some, it's who's in their provider network to be an eligible behavioral health provider. And then some have done an additional step of how many of those people that they contract with actually have billed in the last 2 years for services. And then they've used that as their starting point. And to your point about like billed for services, they anchored the billing to the therapeutic services billing codes that are they're disaggregated for you in the specs, and then also there. And I'm happy to do an individual call, Michelle, too, if that's helpful too.
So just for my clarification, it's not just the taxonomy codes that are called out in the hacker specification. It's far beyond that.
Yeah, because
Okay.
I mean, if you think about the two differences, right? Like,
Yeah.
you know, your part one is like how many kids, component one, the specifications you're talking about,
Mhm.
that's how many kids are getting these billable social emotional services. The second part is how many people do we contract with that we are thinking serve birth to 5,
Okay.
but how many do? And that in concept, that's going to be some of your aha, actually, is that there are people that you contract with that told you that they see birth to 5, but they haven't actually submitted a claim for birth to 5.
Okay, sounds good. Thank you.
Sure, no problem.
Thank you, everyone. And thank you, Colleen, for the presentation and the answers to the questions, and for staying a couple minutes over to answer them. We really appreciate it. All right, Joanne, if you could bring back up the slides. Thank you. All right. We will move on then to another measure that I know sometimes gets a lot of questions, and that's social determinants of health. And so I will turn it back over to Katie Howard to talk about that measure.
Thanks, Jen. So the SDOH measure, its first year is this year, measurement year 2023. And so we did want to make the announcement that OHA will be recommending to metrics and scoring committee that component 2 start in measurement year 2025. It was in the current measurement specs, it says that it's potentially started, potentially would be in measurement year 2024. So we are recommending that it start in measurement year 2025. Component 2 is intended to measure the percentage of CCO members screened and as appropriate referred for services for the 3 domains housing insecurity, food insecurity, and transportation needs. So it is that quantitative component of the measure. And the reasons why we're not slowing down the measure, but instead we believe that this recommendation will allow for more capacity building around screening, referrals, and data collection, greater alignment with similar national metrics such as HEDIS, and then refinement of some of the component 2 requirements before implementation. Next slide. In addition to really get at that aligning to other national measures, we are adding some screening tools to increase that alignment, and they will be in the measurement specs beginning in measurement year 2024. We will also be considering other additions in mid-2023. So if you have questions or comments about the updated list and the added screening tools, which I'll go through in just a bit, or you would like to submit an additional tool for approval, please send us an email in our usual place at Metrics Questions. I think I did get a question in the chat. Will the OHA be aligning with the HEDIS social needs screening measure on the data sources that qualify? We are currently looking through that, and we will let you know, but I don't have an answer for you today. And next slide. So on the next 2 slides, I'm just going to go through the screening tools that were added, and they are highlighted in yellow on the screen. So we are adding the comprehensive universal behavioral screen for transportation. On the next slide, we're adding Promise, Seek, several US federal surveys, and as well as the WellRx questionnaire. We're also removing the distinction in the specifications between adult and pediatric screens. Many of the screens are appropriate for a certain age group within the pediatric population, or in some of the screenings that were listed in the adult section are appropriate for caregivers. So we are removing that distinction, and CCOs and providers should use the screening tool for the population that was intended by the organizations that maintain the screening tool. Next slide. We are offering technical assistance. So OHA's Transformation Center and OHSU's Oregon Rural Practice-Based Research Network, also known as ORPRN, are currently offering technical assistance on the SDOH metric. They are also offering individual TA to CCOs, so you can reach out to them or to us at Metrics Questions, and we can direct you to the ORPRN team. They have a series for each of the sections of the self-attestation or component 1. So screening practices, referral practices and resources, data collection and sharing. And then they added an additional series in the end of May and in June for community information exchanges and other platforms that really can help facilitate data collection and sharing with this measure. In the slides, the links are live for you to register for the webinar series, the Learning Collaborative, and Follow-Up Friday. So, for example, on March 24th, we'll be having the Follow-Up Friday series. And I'll talk about that a little bit more on the next slide. So on this slide, we have put out an ORPRN have put out an SDOH metric learning collaborative playbook. It's an optional tool that CCOs can use to complement each learning collaborative and the technical specifications. We are having the Follow-Up Friday series, so you can come to us with any questions that you have. It's informal, and we'll also be going over the playbook and anything that's come up in filling that out. And the links are live, and you can click on there to find them. We'll also be releasing additional playbooks for each section prior to each follow-up Friday. Any questions about the SDOH technical assistance or measure?
I don't see any additional questions in the chat.
Me neither. Okay, so I will move on to the next section. So today I'm also going to talk about the health equity measure. So it's the meaningful language access to healthcare services for persons with limited English proficiency. Next slide. We just wanted to give CCOs and providers an update that we do recognize that the CCO quarterly reports are have not been updated with the in-language provider with proficiency test. And so we are planning to update the template for the quarterly reports and bring it in line with the measurement year 2023 specs in fall of 2023. So until then, when you are filling out the quarterly reports for your full population for individuals that need language access services, CCO should be referencing the measurement year 2022 technical specifications for guidance. Or you can always reach out to us at Metrics Question, and we'll get back to you to help you fill that out. Next slide. The in-language provider with proficiency test, I just wanted to remind everyone that that was added for the measurement year 2022 sample and the measurement year 2023 specs as optional. And so CCOs are now able to receive numerator credit for component 2, which is the percentage of individuals who receive language access services by a qualified certified interpreter, or now an in-language provider with a proficiency test in the member's preferred language. To receive credit for this numerator hit, the provider must pass the proficiency test within the last 3 years in the member's preferred language. The CCOs must also maintain a record of the provider passing the proficiency test in the non-English language they provide direct care in. And this reporting option is not available to general clinic staff. So that numerator hit was added as optional for measurement year 2022 and 2023. Next slide. So for measurement year 2024, we are planning some technical specification training changes. We are planning to add in-language provider with proficiency test items to component 1, which is the self-assessment survey for CCOs. We'll be providing some clarification in component 1 on items identified during the 18-month review of the measure in 2022. So that happened last summer. And we also, in anticipation of the measure being full population, will be removing the sample language from component 2, which again is the percent of member visits with language access services. We also, on the next slide, you can see here we'll be gathering feedback on the measure specifications. And so we may add some additional clarifications or items to the survey based on that feedback. The timeline for the technical specifications are we're currently drafting them, and we plan on finishing them at the end of May. We'll then be releasing them for feedback in May and early June. So we'll be discussing it at the next CCO tag meeting. And then we'll be finalizing the technical specs for metrics and scoring by late June. We also will be making some minor updates to the measurement year 2024 specs on the usual timeline in November before we post the incentive measure by December 31st of this year for measurement year 2024.
Thanks, Katie. There is one question in the chat from Emily Canales at Care Oregon. She asks, can you clarify, is it only reporting provider proficiency that is optional for 2023? Because it's still a must-pass question on the self-assessment for 2023. So it's optional to report, but still a must-pass components for CCOs to track this year. Is that correct?
Yes, it's only, I believe, and I will also defer to Frank, but I believe it is only for reporting the provider proficiency part. We do recognize that in-language provider is currently in component 1 in the self-attestation items. That remains the same. We'll be adding that additional qualifier of some items for in-language providers that pass the proficiency test. So you are correct.
Thank you. We'll pause for a minute just to see if there are other questions on either the health equity measure or SDOH that Katie covered previously.
Oh, one more question on MLA. Can you please define OHA's definition of wait times for the self-assessment? We have definitely talked about that internally. I'm gonna turn that over to Frank Wu. If that's okay, Frank.
Hi, can you hear me?
Yeah, we can hear you.
Yeah. So the intent is to compare from the time that the member requested the visit to when the visit happens. So this can actually be compared between member who needed interpreter services and the rest of the members who didn't use interpreter services. So it's not the time to arrange interpreter services. So it's the entire wait time when the request of the visit happened to when the visit actually was provided. So I think we actually tried to clarify the language in the question itself in the most recent iteration of the specs.
Follow-up question, if I may, James Wilson with HealthShare. Has consideration or guidance been developed around kind of working through the intent of that metric versus clinical practices? Like I'm thinking specifically, as you know, recently I was with an FQHC with a dental program, and it was standard practice to schedule someone 6 months out. You know, we would regularly schedule a dental visit for 6 months from now. And I'm wondering if there's guidance for, I believe the intent of this metric is to get to an accessibility understanding. And I wonder if there's guidance in moving between the clinical practice of scheduling and, you know, patient preference, individual preferences. You know, I don't want an appointment this Friday, I want an appointment next Wednesday. I'm going to schedule you a dental appointment in 6 months for your recall. Yeah, that kind of thing with the intent of accessibility for members with language needs.
Yeah, that's a very good question. So we've been discussing with Equity Inclusion Division as well on the intent of collecting, asking CCO to collect the appointment wait time component. So I think it's really understandable what you mentioned, like there might be some different standard procedure for scheduling, but we think there is still possibility you can see difference in difference, right? So clinics have different practices, how they schedule, and the main focus is whether it result in different wait time for different population, whether they need or don't need interpreter services. So obviously, if you look at overall average, mixing all kinds of visits, all kinds of different specialties, different sites, that average wait time might not mean too much. But I think the intent of including this in the attestation is whether CCOs are paying attention that getting interpreter services is a barrier to get care. So, and yeah, I think I should also mention that it is a component in attestation, but currently OHA is not asking CCO to report the data to OHA. So the main intent is whether to remind CCO that this is something to look out for.
Thank you. And I think Emily also has her hand up if there's a follow-up to that.
Yeah, thank you. And I'm sorry I don't have my camera on, but James, I appreciate your question. I totally agree. And thanks, Frank, for responding. And I think to that, the point that James made is perhaps, so we currently track a common access measure for us to track within our network is like third next available, right? Because that takes into an account that sure, some people like to schedule out. And so if you're actually tracking time to when the visit was requested to when it happened, that could be all over the map and is largely driven, is definitely driven by access and availability, but it could just be that the members want to schedule that far out based on that's what works for their schedule. So if we measure something like third next available appointment, that's a little bit more standardized and gets rid of some of the noise that I think you were hearing James describe. And so I also appreciate, Frank, your reminder about the intent is, we're not reporting this, the intent is a reminder that we should track it. And I wonder, I think that's where I was getting with my question in terms of it would be helpful to have guidance from OHA in terms of is there a specific measure you want us to track? Or is it just we're measuring third next available, and as long as we're, comparing that for members with limited English proficiency or deaf or hard of hearing compared to the entire population, that's good enough? Or is there something specific that you want us to track that we don't already have built?
Yeah, it's definitely a good question. We will need to circle back with equity including division. I guess one of the potential solution I'm thinking right now is that we could probably change the language for the survey question to more clearly express the intent of this question, but not too specifically saying you have to track wait time in certain ways. So yeah, I don't. This is something that the metrics team definitely work with OEI, Equity Inclusion Division, to come up with these questions and maybe have some pictures in the past maybe transpired or need to be further clarified with more detail from your feedback. So I think we will include this one as one of the items that we revisit the specifications.
Perfect. Thank you so much.
Thank you. And there was another question in the chat, which says, when we move to full population reporting, will the baseline be remeasured based on the full population reporting instead of using chart review rates as the baseline?
I think we're gonna have to circle back on that one with the group. But we can definitely talk about it at the next meeting.
There is another question that just came in from Krista Collins. Thank you for the details there. I'm wondering if Katie or Frank, rather than me reading all of that, if there's specific pieces you want to pull out and respond to.
Sorry, I'm just reading through it.
Yeah, no problem. And thank you to everyone who's asking questions. We appreciate the engagement.
A requirement in this and Frank, just jump in if I get it wrong. A requirement in the self-attestation component is that you are tracking whether your member needs interpretive services. And so that would be beyond the MMIS flag. And so you should be using both of those sources. But if you find that you followed up with a member and MMIS says that they don't need interpreter services, then you wouldn't be required to provide an interpreter for them. Sorry, Frank, did you have anything else to add? I might have missed a little bit.
Yeah, I can jump in. So,
yeah.
So basically, the measure still requires CCO to report on all the members who have interpreter needs flagged in MMIS. But if the member tells the CCO that the information is incorrect and they didn't initiate the correction for OHA to get the flags removed, then the CCO still need to report them for each visit. But the CCO can use a refusal reason to mark each visit that we know that the member refused the services. So as long as the members still have the flags, the CCO need to include them in the report. And on the other hand, CCO can also identify additional members who don't have MMIS flag but have been requesting or utilizing interpreter services.
And that's true for the CCO quarterly reporting, which is currently full population.
And we'll be using the same requirement for the metric on the annual report.
Sorry, just also reading because I see Andrea Kettlehut is asking, isn't 2023 also a sample? It is a sample, but we still require there's still full population reporting through the CCO contracts quarterly report. And the measure, the glide path is that the measure would eventually move to full population when metrics and scoring is full population. Sorry, it's very hard. I'm not great at multitasking, so I'm Dave Elliott.
Just to let folks know, we are trying to extend the Zoom time, but it was originally planned to end at 2. So if we get cut off, please do submit any questions to the metrics.questions email address, and we will respond to you there. But if it works, we'll go another just 2 or 3 minutes to get these last questions in.
Okay, I think the other chat is between David and Krista. Are there any other questions?
I think you got all the ones that were in the chat, Katie. Thank you.
Okay.
But yeah, if there are follow-ups, please do email us at metrics.questions. And I'm just going to wrap us up quickly by saying our next meeting is on May 25th, and we look forward to seeing all of you again then. And thanks everybody for your interaction and engagement today. We really do appreciate it. Bye-bye.
Thanks. Bye.